Everyone. Thank you for attending this special Zoom session on PACE Wellness Hub expansion and the formation of PACE Canada. We're delighted to have Councillor Paul Sharman join us today. Paul has been instrumental in launching PACE throughout Halton Region and now across Canada. He has had an extensive career in management accounting and serving international clients. He's a fellow of the British Institute of Chartered Management Accountants. He served as CEO of the Institute of Management Accountants and was named one of the top 100 most influential people in the U.S. in the U.S. accounting world by Accounting Today for 3 years in a row. Paul's currently the Deputy Mayor of Burlington for Strategy and Budgets and is the President of Halton Community Housing Corporation. SSAO is very pleased to have him join us today to share his expertise and enthusiasm for PACE Wellness Hub expansion across Canada. He's been a wonderful friend to SSAO, so please welcome him.
Well, thank you very much for that wonderful introduction, Trish. It's a great pleasure to be back. I think this is our third or fourth one. I don't remember.
I think it's a third.
Third one. Well, and if you go on to ChatGPT and you type in Paul Sharman and PACE, they come up with the whole story, and they always feature SSAO. So that's a win-win. It's a great pleasure to be back, and after doing our first one a few years ago, where we were just at the turning point from beginning to see the results of our pilot project to now having no question about whether it works, what it is. We now have well-established models of PACE working in Canada. We call it community wellness hubs, but I'll talk more about that. You'll notice on our first slide here, we've got the new logo for Program of All-Inclusive Care for the Elderly in Canada. The name of the corporation is not-for-profit Program of All-Inclusive Care for the Elderly Canada, but we just decided to put a maple leaf in the swirl there, and PACE in the letters there. But fundamentally, our goal is to keep Canadians happy and healthy at home. And you'll understand where I'm coming from as we go through this. I know a lot of people want to talk about the healthcare system and medical system. I actually don't want to talk a lot about the medical care system, because my goal is to keep people away from the medical care system, which is reactive and too little, too late. And certainly long-term care, if we can keep people in their own homes, it's a win-win for everybody. I can never do a presentation about PACE without telling you or reminding you, those who've seen me talk before, I'm here because of my mother. Next slide, please. I'm sorry. Thank you. I'm going to figure this out. We are here because of my mother, who went through in her latter life. I moved from Britain to Canada, and after a number of years, started becoming unwell. We didn't know who to send her to, because she had some problems with the kid upstairs, and she was feeling that he was intruding on her space. And so we sent her to a gerontologist, and the gerontologist said she was a schizophrenic. She was a paranoid schizophrenic. Well, I'm not sure that's a diagnosis, but that resulted in medication being given to her, and within 3 days she was catatonic, and it took us a long time to get her somewhat back to normal-ish, and then eventually on the path through long-term care, and eventually dying through pneumonia, and all of it was horrendous. Next slide, please. So my sister and I vowed we would make a difference to the system. And when we were talking about that, we weren't really aware of the data I always use this slide for, which is recognizing that the number of people over the age of 75 is growing so rapidly that when my mother was going through her latter days, there was healthcare system capacity, there was long-term care capacity, there was retirement home capacity. We didn't have COVID to cope with. But then you think about, the curve there, which shows that the number of people increase over the age of 75 is increasing at the rate of 3.5% a year. We had 90,500 excess deaths in Canada because the healthcare system could not deal with everybody when it was so focused on COVID. And then you get to today, which is only 3 years later, 4 years later. In Ontario, we have only 77,000 only long-term care beds, and we have a waiting list of 50,000 people. I'm told in Ottawa they have a waiting list of 10 years. That's not a waiting list, it's a death list. It is only just beginning to go up the curve. So, we got much worse coming, and we need to think about how we deal with the with our own lives and those of our loved ones, and how we prepare people for the journey. Next slide, please, Harry. So, it's a bit of a journey how we got to bringing PACE to Canada. But really, when we talk about program of all-inclusive care for the elderly PACE, I have to tell you where it started from. And it started in San Francisco in Chinatown, and I actually think from our point of view, that we need to appreciate the Chinese philosophy that is defining how we look after our older adults and all of us as we age. And that is, using this Chinese philosophy, where the name Onlock, which was the service center where it started, means in Cantonese, peaceful and happy abode. So when I say happy and healthy home, I really am proposing we follow the Onlock protocol, the philosophy. And the vision is enabling seniors to age with dignity in their own homes and communities rather than in institutional settings. And, it is a true fact. Canadians are allowed to die in their own homes. We can be unwell in our own homes. And actually, we want to be in our own homes. So I know that in Canada, our universal health care is deeply appreciated, and frankly, I believe that that's appropriate. So do not think anything about PACE and the Unlock protocol is about the medical capacity or the nature of our healthcare system. It's something that universal healthcare gives us confidence, which if you go into the United States, a lot of people have poor confidence. If you go elsewhere in the world, without a universal healthcare, people have huge risk. Ours is mitigated to a very high degree. The thing about what we're doing in this Unlock model is that it is in addition to the healthcare system, the medical system. And what we recognize is the comprehensive care model, starts when people need some attention. When if somebody loses their driver's license, it's the beginning of the end. Or if somebody's, starting to have some, mental challenges or physical challenges. I was talking to one of our new members who's a surgeon, and he does surgery on ankle joints and hips and things like that. And he said, what, at the age of 30, our bones become weaker and weaker by about 5% a year or something like that. And it goes on and on until we get older. And then also as we get older, we might trip and fall. And then we deal with muscle atrophy as well. But he says these things can be avoided to some degree by taking preventative steps. And his comments are, if by the age we're 60 and we're eating almost 200 grams of protein a day, and we're doing resistance training, that will help us strengthen our bones and then give us a longer and better life once we get into our 70s and beyond. And really, it gets into the very notion of Unlock is it's integrated collaborative care between the social services and all the support mechanism everybody needs. And we've got a picture of someone driving a bus here. And central to PACE is actually in PACE is the articulation of the Unlock protocol. PACE is in 33 states, 86,000 participants, not patients, applying the Unlock model. But the critical issue is with the bus is they work out of centers and they pick up everybody at their homes and take them to the center. for some activities, and adult daycare and laundry and things like that, and food. But they also have services in those folks' homes. And so the whole notion of integrated collaborative care, a wraparound service that includes healthcare when you need it, but mostly wants to keep you away from it for as long as possible, does not want you in long-term care, and doesn't need you in retirement homes, because frankly, people want to stay at home for as long as they can. And we'll talk more about small homes as we go on, and retirement homes. Everything's necessary and has a place, but I think most of us would like to stay in our own homes. So there's the notion of the subject we've been talking about. Then you'll see, halfway down the slide, it talks about interdisciplinary team, which consists of physicians, nurses, social workers, therapists, home care coordinators. And the core philosophy is it's person-centered. It prioritizes independence, dignity, quality of life. And who amongst us does not want that for ourselves and our loved ones? Next slide, please. And here we get into that notion of the interdisciplinary team. So the way this works in the United States, they've got all sorts of regulations, and the way they've done that is related to, and each state has its own regulations around how PACE is applied, but it's still on lock. Center to that is the multi-interdisciplinary team, the PACE interdisciplinary team, or the on-lock interdisciplinary team. So what we have here is, you'll notice around the circle, it's got primary care in there, but it's also got social workers and therapists and nurses and dietitians and the bus driver and the personal care attendant. And in the bottom, at the bottom to the right, there's somebody called a home care coordinator. And the critical thing about the home care coordinator is that person is working with every individual participant, managing their days, managing their calendar, organizing when, for example, a PSW is going to visit, making sure the PSW who comes is always the same one, making sure they're on time, they're working with the providers. And that is true of every aspect of the relationship of the individual participant, the home care coordinator, as well as all the other members of the interdisciplinary team. The role of the interdisciplinary team is to work with on a daily, weekly basis with the coordinator and the participant to make sure that everything that the participant wants in their lives and what they need in their lives is taken care of. And they talk to each other about this. They work as a team, and they value, as it says, a holistic care model that supports independence. As I've said before, 97% of PACE participants live in their own homes. Another statistic worth knowing, 70% of PACE participants die in their own homes. This is in about 33 states, 352 centers, 88,000 seniors, all applying the original on-lock protocol in a very disciplined way. Next slide, please. For my journey and understanding the on-lock protocol and learning about PACE was in Southeast Michigan, where I had been invited down there by a man I'd known for years who worked for Chrysler, a senior finance person, who was at that time president of the Presbyterian Villages Homes organization, working with the United Methodist Home organization. And they had 5,000 small homes. Picking up on Trisha's language, small homes. They had 5,000 of them, but they were not on the ground. They were in this building, a bunch of them in this building. What you see right in front of you is something even more wonderful, which is called the greenhouse. And there they had about 8 or 10 individuals around a common living area. And to some degrees, it was hospice. To other degrees, it was people who are sort of in rather critical ways and becoming better. And some people got back into rooms in the rest of the building. It's a very spectacular place. I'm trying to organize a trip to visit them in March. Um, Not only does the PACE Center in this building serve the people in the building, it also serves people within a 2 mile per radius around the building. And so it's also doing the same work as PACE across the United States. It is this that inspired us to bring PACE to Burlington. So, you know, I was on the way back from Detroit with Rick Goldring, the mayor at the time. You know, his comment was, you know, we've been trying to figure out how to help seniors have a better quality of life in Burlington, as you know, but the PACE thing rocks it. And he said, should we do this? And we agreed we would do it. And then he turned to me and he said, we're in the car, and he looks at me and he says, Paul, you're the consultant. How are we going to do that? So we're looking for great things. Next slide, please. Um, so the question was, what is this all about? Why do we need this? And so there are a few points here that are worth just reminding you, because you know this already. I've already mentioned the aging population. By 2040, we'll have 60% more older adults. So 4.2 million people in Ontario. We'll have, it peaks in 2050. We know that number is way bigger across Canada. We know that complex care needs in older adults is increasingly causing situations of social isolation, chronic disease. Gosh, our hospitals are now scheduled to get people in, get them out, get us out, and find a way for them to live somewhere else, because they're not paid for when we're hanging around and just, starting to take up alternative level of care space in the hospital. And then that leads you to so many other aspects of the last days of our life. I was hearing recently, a friend of mine was talking about a family member who's got an accelerated form of dementia, and because in Ottawa they couldn't get into long-term care, he was in a halfway house, and she went to visit him, and she found naked people in wheelchairs in the corridors, and really were not well looked after. She had a horrifying story. Truth of the matter is, we all want to live at home until the day we die. The question becomes one of, so where is the care model that would make that happen? What we know in the United States is that they have what we call capitated funding. And I know that SSAO has been advocating for all of its time to have funding provided by the province to family members or power of attorney, whatever it's going to be, to look after mom and dad or our loved ones in a way that suits them best. I mean, I don't mean the care provider, I mean the loved one. And that's part of our goal in PACE. The problem we have in our care model is, number one, is it's reactive, it's too little, it's too late. We know that when we get into home care and things like that, we have all these organizations across the country, but they're disconnected. They're not coordinated well. We know that people don't turn up on time to important meetings with an individual, and they maybe have an hour and a half a day of PSW time. That's not enough. It needs to be minimum 2 hours, but it's half-hour chunks, so they can take four visits a day. Even in our own community wellness hubs, where our pilot projects have been, it's limited to 1.5 hours. It's not enough. So we have a whole bunch of disconnects, fragmentation, and duplication of effort. We haven't got an integrated collaborative system. And then you get into the funding from the government. I understand that the challenge in Canada is that, especially in Ontario, we are fighting all the time to put more money into the reactive care system, as well as Ontario Health at Home, who I have a high regard for. But they need more reserves, more services, and they need to work with the care providers to be more integrated and collaborative. In any event, this leads to negative health outcomes, poor quality of life for older adults, family and caregiver burnout, and there are increasing pressures on the Ontario healthcare system. I am concerned for us today. My mother had access to capacity, and it wasn't a good journey. So what's going to be like for the rest of us now? We need to have a different answer. Next slide, please. I'm not going to spend a lot of time on this slide. I could go on for quite a long time about how we started in 2017 and went through a program, a process of working with community members to identify how we would implement program all-inclusive care in Burlington. And then in 2019, we started our pilot project, and I'll talk more about that. Fundamentally, though, this was not simple because we had to think outside the box. You know, nobody did this in Canada. Nobody was doing this. We had to go and work with the folks from Detroit. We made a number of visits down there to figure out how on earth they were doing what they were doing. And learning about the Unlock protocol is central to our ability to move ahead with this. So when I hear people across the province saying, well, the Community Wellness Hub is great, but then I find out that, well, actually what they're doing is they're putting all the service providers in one building or in close proximity, but they're not providing the the care model, the integration, the interdisciplinary team, and the home care coordinator. And so what we're doing is continuing with the fragmentation and the disconnects and these silos, and even having laws that say, you can't look after somebody who would be eligible for long-term care in a retirement home because you haven't got enough people. But we haven't got enough long-term care. So shouldn't we be adding more people into those places where those older people are and looking after them where they are instead of putting them into an institution? Next slide, please. And here it was, 2019 in the winter, we started up this PACE pilot project. It happened to, we wanted to work in the way we'd seen it in Detroit, which was put a PACE program in a building, a residential building, and it needed to be one that we controlled. And the building was one of our Halton community housing buildings at 410 John. And it was one of the buildings where they had a significant amount of distractions. The residents were struggling. They had high number of calls to the emergency department. There was a lot of anxiety, a lot of depression, and families family supporters were not that happy either. But anyway, we started this in 2019 with significant support from the community, the regional Halton, our social services group. In fact, most of what we've accomplished with PACE is a result of the work of the regional Halton, our social services, and we had an anchor table which was significantly EMS, police, and other organizations that around which we initiated the care model, set up the interdisciplinary team. We created a project charter which we're happy to share with you. And invested $1 million in updating the building, especially the ground floor, so that we had places where service providers could come and visit with residents in the building. And if a medical person came, they could go to the individual's apartment. Today, we have 80% of the members, the residents in that building, are signed up as members or participants in our what we call our community wellness hub, inspired by PACE. But that's a significant proportion of the community. In there are on-site community connectors. We call them that in a community wellness hub. It's the same thing. It's the home care coordinator that works with the interdisciplinary team. So we have those people in that building. We have the interdisciplinary service providers. And they're working with the individuals in the building as well as the coordinator. And we have a lot of activities organized by the region and other services. So the last few years we've been there in December for a Christmas party, and they're all in the room and they're all cheering and smiling, having a good time. And I get an opportunity to say, how do you like what we've done here with the Community Wellness Hub? And talk about PACE, and we get cheers and they love it. Next slide, please. Our friends in the Ontario Health Team have been very helpful with us, facilitating the research and the monitoring of what's been going on there, and with the province, they built this notion of the quintuple aim. So 5 goals that deal with the PACE principles. The first thing is upstream care is more cost effective than acute or long-term care. So the better we keep people earlier, then the more efficient and effective it is for the system. But more importantly, it provides for happier and healthier people. It's certainly more efficient for the service providers. But then you get into advanced health equality. And what it means is that actually we are serving everybody in a more equitable fashion. Because a lot of people, they wait till they become unwell or they can't get the service they need because they don't have a doctor or whatever. We're seeing that actually, if we advance our care model to be more focused on the social determinants of health, then it becomes less of a reaction to actually a real health problem created by lack of attention. We know about people prefer to be at home. They want trust to trust their providers between the participants and the care providers. And we go on to talking about the integration of these things, and so the experience is positive. Early identification of an upstream care, we talked about that, reduces acuity of care needs. I talked about the surgeon who said, yes, absolutely, we can reduce the amount of hip replacements and joint replacements by doing upstream preventative care. And we had a meeting recently about homelessness in Halton. And what we know is about 50% of the homeless people we have in Halton suffer from mental illness and certainly social isolation. And my question of the commissioner was, do we have any statistics on how many of those people had mental health issues before or when they started being homeless, or how much of that would be caused by being homeless? I'm sure for me, if I became homeless, I would develop mental health illness, especially in weather like today. Anyway, so it goes on, improve provider communication, improve sense of team. All of this is about, process design, integration, collaboration, and making sure that everybody's got a solid set of goals around looking after the participant. Next slide, please. Very quickly, talk a little bit about, after 5 years, our pilot project results. First one was the people in the buildings, the participants themselves, they felt better about themselves. As I said, those people were happy, and when we go and visit with them, they always, mention the community wellness hub. Remember, that's our name for PACE in our pilot projects. They're happy and they cheer us and they think it's wonderful. We know that there were 31% lower hospitalizations for those who needed ambulatory care. So that's good. We know that there's 70% fewer, less non-urgent ED visits. So the way we calculated that is that Ontario population age 65 plus, the emergency department visits were less than non-urgent, or that were less or non-urgent, were 20% of the population. In our pilot projects, we're finding it's 6%, so that's 70% less people. That is a huge accomplishment. Next slide, please. And then when you get into some of the other interesting data, if we were to think about this being scaled across Ontario, and we were to continue less non-urgent demand for ED, that would save the Ontario government $1.3 million a year. We would have 3.4 times less the average healthcare system cost for people with similar profile to those who live in community wellness hub and PACE. We know that we could save the Ontario government $90 million a year per 100,000 older adults who were participants in our PACE program. Those are very substantial. So if you think about the number of people who want support, these numbers could be significant. I would add that for every 100,000 people where we save the Ontario government $90 million a year, there would be an economic leverage of maybe another $200 to $300 million because the care providers would need more resources. And that's when you get into the capitated funding that they have in the United States, where actually we need to help pay for additional resources so people can stay at home, but it's good for everybody. And I just saw a message on the online there, how our family and friend caregivers supported. We've been very delighted to visit recently an Acclaim Health property in Oakville, where they not only have adult daycare for the older adults who are being served there, but they also have caregiver sleepover, so you can go and stay there and get respite. We could see more of that. But furthermore, with PACE, we'd be using professionals and would be less dependent on family caregivers. So it's a question of how we build a system that is very sensitive to the needs of everybody, including the caregivers. Next slide, please. Today there are 8 community wellness hubs. I know the Ontario government is talking a lot about deploying more community wellness hubs. My own sense of that is they would be still within the regime of the healthcare system, Ontario Health Team, and really the health system is not the right place to be doing this, because by the time we get into the healthcare system, it's reactive. Too little, too late. We need to help people get involved with finding the solutions, keeping them happy and healthy at home much earlier, much upstream, low acuity, which we've already proven we can do that. There are issues around housing accessibility, but what we are working with as you'll hear me talk about members of PACE Canada, we have also people who can help make your home more suitable, more accessible. There are a whole lot of issues. One of the things that I believe is that central to our pilot projects, and now our 8 centers, 2 of them in Hamilton, the housing is critical because we all have to have somewhere to live. But the more important thing is the care model. Keeping people happy and healthy at home is more about the care than it is about the home, if in fact you can stay in your own home. I'm a bit agnostic as to which home they're in. It could be in a condominium, should be in condominiums if that's where they are. It's kind of tough to be doing it in a social meeting room to have those services. And the condos and the rental tower is going to have a hard time spending $1 million to improve the amenities. But frankly, we can work with people in their own homes. And that's how I see this evolving. We need to build the unlock care model and make it available to adults. Next slide, please. So I want to talk about 265 Kerr Street, and this is what triggered Trish inviting me to do another workshop with you, because this represents this property, which we opened in September of 2025, is the first custom-built PACE center in Canada. You will see on the ground floor, in this picture on the left, you'll see there's all sorts of windows. That is where we have the meeting rooms. We have space where people can hang out with each other. We have rooms that the doctors can visit and other service providers can visit with individuals, but they can also go into their rooms. The fabulous thing about this is it's owned by a community, a Halton Community Housing Corporation. The second floor is for housing people who are in transition from homelessness, and so what we even have in there is furniture that they can take with them when they leave and go on to have their first home. The next 2 stories are about 650 square feet. They are the small homes that you're talking about. We've done it. It's here. custom built. We absolutely demonstrated we can do it. We know how we run it. It happens that you can't see behind here, but we have another building which is 271 Kerr Street. There are 242 seniors housing units, which are supported and assisted housing, and they have access to the community wellness hub services here as well. We were delighted with this one. We built it in about 2 years. We got regional funding of 16 million and federal funding of 15 million from the province, 9 million from the federal government, 16 million from the region. It has 52 units in this building, and that works with the 242 in the other building. This is spectacular, and you can see we were very happy when we were opening it there. Next slide, please. I wanted to just give you a sense of what this looks like. You will see on the top left-hand corner of the ground floor layout, we've got a residential lounge there. Then we have on the bottom, we've got this thing called Hub Lobby. Well, we've got the office for our home care coordinators, and we've got the supervisor of the building. We've got additional offices below those where we can have meetings with individual participants. And then we've got, of course, the dining area, and then we have a multi-purpose room. And we're doing all sorts of programming in there. We've even got, a scooter and bike storage area up on the top in the center. Many, many things. And this is here to serve all the people in all those two buildings. In terms of operating this, we have about 12, 14 different service providers. It starts with Halton Region Services for Seniors, so our recreation coordination. We have Food for Life, Halton Regional Paramedics. We have a transportation organization, Reimagine Ontario Transportation, Centre for Skills Development, Prime Health Milton, Alzheimer's Society, Oakville Meals on Wheels. We have the family healthcare team available. We get services from Acclaim Health. And we also have the home care coordinator provided by Links to Care. So this is the interdisciplinary team that I was talking about, and they get together and they meet, and they can do online meetings with the care coordinators and with the individuals. So this is the first a relatively small. It's about 4,500 square feet. Some of the centers in the United States are more like 20,000 square feet. But they're serving a very large community of people who work around the outside the center and 2 miles radius around, and buses are bringing them in. Next slide, please. So that's reality. That's where we are. I want to talk a little bit about comparing the US versus what we've got as our pilot project. So in the United States, to be a participant in PACE, you must be 55 years old or more. You must be nursing care eligible, so long-term care. You must be Medicare, Medicaid eligible. This is the capitated funding. We don't have that. And that we need to change. And so, Trish, whenever you said that in the past, I agree with you. We need it. But the fundamental point is most of these people are living in privately owned homes, whether they rent them or own them, but it's somewhere they want to be and they're happy living there. And the notion of all this is a diligent application of the on-law protocol. So in Burlington pilot project, typically people are over the age of 50. But in the 265 Kerr Street example, we don't have an age limit there. And what we found is people who are homeless, for example, they tend to be physically older. Their bodies are older than their actual age. Everyone's entitled to 100% of universal health care. We are not planning to. We don't see how you would change that. The healthcare system has to change itself. But as we work to keep people happy and healthy at home, maybe the healthcare system will start to adapt and think about, okay, this is working. If we can keep people away from the hospitals and out of away from the doctor's office, and we can service them maybe without even seeing a doctor, and you're just thinking, I lost my mind. I'll talk about that in a minute. Then we can make lives easier on our healthcare system, get better use of the capacity we have, and reduce the cost. Housing and community housing is all HUD subsidized. We are essentially within our existing community hubs. They're all within community housing, which means for essentially it's all government paid for. The question for us is how to make it happen for outside of the community housing corporation. I'll come back to that in a minute. Anyway, so there's the notion. They are different in ways between Canada and the United States, but the on-lot protocol is philosophically identical. And that's the point I've been kind to make for everybody, to say to everybody, is that when we talk about looking after old adults, in Ontario, we talk about housing all the time. Actually, the biggest issue we don't have is service care all the time. And that is the key differentiator. Next slide, please. One thing I wanted to talk about was the difference between older acuity, multiple acuities, the morbidities rather, multiple morbidities. What we find is that at the various levels of when we find things wrong with us, what do most people do? You might say, well, we'll go and see the doctor. But getting to see a doctor is not easy. You might go to the emergency department, which is certainly a waiting proposition sometimes, and they're overworked. Some of us just go on Google. In fact, all of us go on Google. And really what we'd like to do is have a place where they can go and get advice from people who are well informed and to whom they have easy access. Then you get to the next level, low acuity, high acuity, critical acuity. We find that we know that from the experience in the United States, the earlier we get to somebody in that acuity ladder, the better off that person's going to be in terms of quality of life and health. Next slide, please. So where in PACE Canada fits in? Well, we've been really lucky to be able to work in community housing, and we didn't have to immediately start with people with multiple comorbidities and high acuity. Although we do have people who are in our community housing buildings. Who we just were visiting one of our buildings, and I asked about how many high acuity residents do you have, and the answer is we have 2 who are on the emergency list to go into long-term care. And I said, well, what does that mean? Well, they have no room in long-term care, and we have so many people wanting to go in. And my question is, why don't we just continue to look after them all the way here? Why do they have to go to long-term care? They're better off here anyway, because we have a more home kind of friendly, empathetic environment where they get the attention. And the answer is, well, we don't get enough funds to do that. We're not allowed to have those people. And I'm thinking, really? You can die in your own home. You can be looked after in your own home. But if you work if you're in a retirement home, you can't be there. You have to go into long-term care. And, it's because of cost and money. And we're really not thinking it through very adequately. When it comes to housing, what's wrong with us being where we are and living to the end of life? Right? So we need to be thinking broadly from a process perspective about keeping people happy and healthy at their own home, from the lowest needs right the way through to end of life. I repeat what I said earlier, 70% of PACE participants in the United States die in their own home. Next slide, please. I want to talk about the way we think about care. As we see it from a PACE Canada perspective, we're less concerned about trying to change the healthcare system, more concerned about trying to help it. And the way we help it is by focusing on increasing social work environment, increasing community development, and and programming so that we can get people into programs that will help them achieve their own goals. For example, we're working with a group called Java, based in Vancouver, who happen to operate also in the United States, where they work roundtable or centers, meetings with people who suffer from anxiety and depression. And they have a very well-defined methodology that actually brings people to a place where they're more confident and less challenged. Yes, we need to deal with primary care accessibility. We need buses, actually. The one of our problems today is that, in Burlington, for example, we have these buses called handy van. But in order to get on a handy van, you have to have a doctor's certificate. So what happens if you're low acuity and you don't get a doctor's certificate? Well, then you have to use a taxi or an Uber or a city bus. But it's possible you have to walk 400 yards to get to a city bus, and people don't do that, so they keep driving for as long as they can. We need to change our transportation system so that we can get them to events. We can have people, so I'm just responding to Donna's note here. Yes, in the United States, people live in their actual own homes. It depends on whether or not the building is suitable for the nature of the support mechanisms they have to have. Furthermore, there are other matters that we have to consider. So we've been working with other cities, communities around Ontario, and I've got colleagues in our group now who are working in the rural areas of Saskatchewan and Alberta, and that's non-trivial. We know that there's less resources, primary care is less available. We know that those people don't necessarily have lots of personal resources, and there's a lot of distance between people. But so we know we can use we have people who can visit, but more importantly, we can use technology to help with that. But then you get into actually what I'm really talking about is social determinants of health. So income, all those kind of factors, how we can get volunteers to work with us, how easy it is to have a job. All those things influence how well somebody lives. Next slide, please. And to that point, when we get into social determinants of health, the healthcare system fundamentally deals with the body. And the body is a recipient for bad news and then becomes challenged. But by the time we're dealing with the body failing, we need to go and see a doctor. So the medical system is reactive, and we know challenged by the sheer number of patients and the lack of capacity for the volume of people and increasing complexity. But when you get into the social determinants of health, it means we got to look after the brain, psychology, we got to deal with social factors. My mother loved classical music, but would refuse to join anything. But when she met somebody who loved classical music, there would be a bonding. So we need to actually make sure that we have enough activities to make sure that people have something they can relate to, where they can join in and feel party to it. And then, of course, there's the spiritual aspects as well. And let's face it, if you take a look at our diverse culture today, in Canada, increasingly so, spirituality, and we're just talking to some people who from the islands, where their comment is, we need to have clubs like this because we already know each other, and we know what we expect, and we know things that we like to do and what we don't like to do. But when we get involved with other care providers, they don't know, and we have to spend a lot of time, searching for something or struggling to explain ourselves. So we actually need to think about this with a very broad mind and a high degree of empathy. Next slide, please. And then you can see the slide here. It talks about the characteristics of what we mean by bio, and what's the current health, what's the past health, what are the health behaviors, and then with respect to social, family or friends, and we're also different. And we need to be able to address all those factors, the psychology, personality. You know as well as I do, every single human is different, and we need to be able to address those characteristics. One size does not fit all in any way, and especially in spirituality. So aging is not just physical, it's emotional and social and existential. Loneliness, we've got a new group called Genwell has just joined us, and they're dealing with loneliness. In Britain, they have a loneliness minister of government. We need to deal with loneliness. In my ward in Burlington, perhaps 30% of the people who live in the houses south of the QEW are older adults, many well into their retirement. And really, we don't have any way to get to them. I'm getting phone calls all the time. Just people want to talk. It's I love to do that, but we need something more better organized. Anyway, so the biosocial spiritual model acknowledges that to age well, people need more than a medication or hospital visit. They need connection, mental stimulation, dignity, and purpose. I remind you of the medication given to my mother that was probably meant to be for somebody in long-term care who was acting up, and it basically made her catatonic. That is not acceptable. Next slide, please. Anyway, I'm going to skip the next slide. I think we've covered that enough. Next slide, please. It's the things that are missing. Maybe the slide before that, please, Harry. There we go. What causes challenges for us as we get older is the things that are missing. And we need to have a pretty comprehensive understanding of our needs. When you go to the doctor, what you get is pretty much one question. What's up? How are you feeling? When we believe that what we should be doing is having a whole conversation with you about your life. So how are you doing? What are you up to? Did you walk your dog today? Do you have a dog? And how's your sleep? Lots and lots of different characteristics that can help us understand the quality of life of the individuals. And eventually we know that if we talk to pretty well everybody in a caring and interested conversation, you learn so much about them. There are better ways to deal with at-home care as well, which I will talk to you about in a minute. But in any event, aging in place is not just about staying at home. It's about staying connected to life. Next slide, please. So why PACE in Canada? So just as they found in the United States, in San Francisco, in Chinatown, all the problems they found in 1970 exist here in Canada. Our existing support services for older adults are siloed, they're fragmented, they're disconnected, and they're duplicative. Even when I talk to the existing care providers around here, the big corporations who provide services to older adults, they go, "Yep, that's right. That is entirely true." We don't have our government entities that provide care, starting with the doctor. They're kind of doing a bit and then handing you off, doing a bit, handing you off. Oh, you're going to the hospital. Okay, well, do what we got to do, hand you off. Oh, there's nobody to hand you off to. So sorry. Well, just wait. We'll find somebody. And if not, well, we'll find out where you go. But there's no plan. Our health system is reactive. It's too little, too late. Our community wellness hub based in community housing is only a pilot project, but it demonstrates what needs to be done. And we know that by keeping people happy and healthy in their own homes, we're getting great results. And I've already told you what those are from our pilot projects. The other community wellness hubs, PACE Center kind of things, their numbers are exactly identical. We're having huge breakthroughs. I've already told you about 97% of the PACE participants in the United States live in their own homes, whether they be rental, whether they be small, whether they be big. But what you need to know is that community housing can only support 5% of the population. So it's wonderful that we can get them in our community housing buildings, but there's another 95% of the population who don't have access to these community wellness hubs, in community housing. So we actually have to devise a system where we can get to everybody on an individual basis. Um, I've worked with people who live in condominium towers and found that the social committee doesn't want anybody in there. We've worked with the rental buildings where the rental company that owns the building certainly doesn't want too much organization around seniors being in the building, even though there are a lot of them, because they're worried about the value of their investment. So we actually need to just go to the individuals and get to them and provide them the care they need. Finally, I just want to make mention here, rather than pay $7,000 to $10,000 a month rent, perhaps we would be better off if we could stay in our own homes, and then perhaps use a small mortgage, reverse mortgage, to get some support from service providers. Yeah, I know. I just saw a message around Norks. I'm very familiar with it. I started up doing self-help groups in condo towers here in Burlington back in 2012. And we were successful in a few buildings where they had strife between the community members. We were unsuccessful in other buildings where they had they had social committees and boards of members who said, no, we don't want this to be a seniors housing unit. Because they have the concern that it will affect the value of their homes and their properties. I understand Norks, but there are not a lot of them. In all truth, in the United States, in New York, yes, they are, but that was been very differently organized than we have. We have a free capital market for property owners, so we need to talk more about community health. Yes, thank you. Next slide, please. So PACE Canada, what's that? So I incorporated a program of all-inclusive care for the elderly in Canada at the beginning of last year. And the reason I did that was because I realized that if we could only provide through community housing support to 5% of the population, the other 95% of the population needs a lot of help. And that requires us to have a heavy emphasis on social care and support mechanisms to the individual. So we agree. The PACE Canada is a registered not-for-profit association, and with the purpose of promoting the services of service provider members to older adults. PACE Canada will have members who are dealing with services, housing, even products and services, software support. We already have members who offer personal PSWs and private nursing and care providers. We have other members who are able to provide develop care programs for people who are coming out of ILC. We have a whole lot of people who are joining who are very, very qualified. The way it will work is the members, the service providers, will pay a membership fee to PACE Canada, but PACE Canada will not charge anything to the participants. Other people call them patients, we call them participants. Our goal is to keep them not being patients, but we don't want to charge them a nickel. If you have to pay for private services, yes, but we also want to work with people who need access to volunteers and government funding programs as well. We want to do that too. Our general view is that actually, if the largest amount of wealth is in the hands of older adults, we can actually, if we recognize that our care model, our primary care model, is reactive and too little too late, that we actually can take steps to improve the quality of our life, and maybe paying for some of those private services would be helpful. People do already. In any event, what we will do in PACE Canada, we will work with individuals. It will be an automated interface where people can have a conversation with us. we will match them up. We'll have onboarding mechanisms, and we will match them up to the service providers that will meet their needs. So that's the game plan, and requires an awful lot of discussion. But we're building the model. We already have about 50 corporations already signed up. This will make you laugh. One of our service providers is a qualified happiness consultant. So part of our whole part of our goal is right now is to begin with community development and programming that will engage older adults in doing things they enjoy and cutting back on isolation, even things like armchair exercises and so on. Anyway, we do know also that every participant, because we've got universal healthcare, will continue to be funded for their healthcare through the universal healthcare system. We're not challenging that. We don't want to fight it. We want to collaborate with them and make sure that our participants get all the care they need from every source they can. And I have to be, did I ever tell you, Trish, when I was about 5 or 6, I was in the car with my mom, and I have no idea where this came from. I said to my mother, Mom, I want you to know I love everybody in the world. And my mother said, that seems a little ambitious. So if what I'm about to say sounds ambitious, you'll know where I'm coming from. But we believe that using AI and proper technology support tools, which are absolutely available today, not in Canada, but they are available, and we can build them. They're already building these empathetic AI agent interfaces. Our goal is to provide service to between 500,000 and a million participants in the next 5 to 10 years. So that's our wild and crazy dream. Next slide, please. So in the next few years, we plan to offer a scalable, localized, community-based model, which will be across the country. We already have members who are in Saskatoon and Alberta, and across Ontario. We know that there are about 5,200 service providers across Canada who are providing support to older adults. We know some of them are already in every province. And whether the pharmacist or the physiotherapist, they're there and they're wanting to join us. So we're already in conversations with those organizations. We believe if they all joined us and created a collected, integrated, collaborative system where anybody across the country can check in with us, we will connect them to who they have to be with. When we talk to our AI specialists and we say, what do you think of that? And they go, that's a fabulous idea, Paul. And then we ask them, so what's your concern? What do we have to be most anxious about? And the answer is the one you already know, and that's, do I trust these people? Which means that we have to build a system that's highly trusted. In any event, you already get the drift of where I'm going with this. We already have about 65 or 66 members as of today. 40 or 50 of them are corporations. We've got a bunch of volunteers. We have a surgeon. We have doctors. We got medical people, and as well as all sorts of other practitioners. So it's beginning, and this is only in a few months. Next slide, please. I want to talk to you very quickly for a few minutes about technology. This is where I start off. This is working with some folks we've met in the United States. This company, Constant Caregiver, is an EMR system, so it's medical records, but it's working with other technology so that they can be sensing what is happening in somebody's room, and I'll show you the sensors and the nature of it, so that they can then identify if there's something going on. So everything that the doctor would like to know when you go and see them, they will already have from this kind of service. With monitoring, they can then figure out, okay, who needs attention. They can do simulation modeling in order to take predictive care, and then they'll help people get the help they need. Next slide, please. This is what is happening today, not in Canada, but we can have it in the next year. And it will all be managed in data centers in Canada. The data will not be accessible by the administration ever. But it'll be monitoring things like, are you sleeping well? Uh, how's the bathroom going? Um, what about washing? What about how's your emotional scores? They've got equipment that can measure all this stuff, even when you're out walking. Um, so independent of the electronic medical records or electronic health records, all of this information can be gathered legally as information, but it will be informative. And so one of our members has doctors who work remotely with people who aren't attached to family doctors, and they can write prescriptions and they can monitor everything that's going on. Next slide, please. Here are some of the wearables. You'll see that there's over the counter kind of wearables. The watches that we wear. I have a Samsung that tells me how well I sleep. I don't always get good scores for that. Full monitoring. One of the things that we have, the ambient sensor tracking on the bottom on the left-hand side. They have a device about the size of my hand that has a laser radar in it that's monitoring vital signs, even down into you see the one next to that, intelligent incontinence monitoring, other biometrics, real-time fall detection. There are about 200 of these devices that can be distributed, and the software and the technology to analyze it, to do simulation modeling and take preventative steps exists today. We have technology that can be deployed. Next slide, please. Anyway, and this is about something called Team Care Pal. It's operated by a lady called Cindy Sim, who's based in Alberta. This is a version 2 that's coming out. What she has done is essentially built a community of care software that monitors. You'll see the screen on the right, the bottom personal phone, where they've got a schedule. Well, they are monitoring, they're scheduling everything they need through the software. The families are posting messages, the care providers are all linked in, and they're building a community of care. They, by the way, are collaborating with the equipment and the software vendors on the previous slide, and they are going to be deploying it in its first pilot project of the combined service actually in a retirement community in Saskatchewan. This same thing is all going to be deployed in rural areas in Alberta too. Next slide, please. I want to talk a little bit about the workings of PACE Canada. You know our value proposition. You know what it is we're wanting to do. We have what we call habitats. So we have an overall ecosystems designed around the bigger vision, but then we have a whole series of habitats, and the habitats are where members, service providers, and volunteers get together to create plans and to create evolving and improving the methods available to people. So membership value proposition is the first one. Participant care planning, interdisciplinary teams, coordinator enrollment. The third one is technology architecture and participant interface. The fourth is research, professional development, credentialing, education resources. The next one, consultancy services. And we're already working with different organizations who wish to have these PACE centers in them, want to provide care to older adults. We have another group, strategy, marketing, and fundraising. And the last one is community development and programming. So we're making headway. These things exist, and we're moving along. Next slide, please. So the corporation is up and it's incorporated. We have a board of directors who are significant, all senior people, a management team, very capable, experienced. We're having monthly workshops online with all the service providers. I told you about the habitats. We got service providers, volunteers, technology, for-profit, not-for-profit, volunteers, even government funded. They're all critical contributors. We have projects. Our website will be out in the next, I'm being told, the next few weeks. For anybody who's interested in joining us, signing up is really simple. Just send me an email, which you'll see on my next slide. Here's my jab for you. Join us to care. We'd love to have you join us and help us create and deliver a higher quality of life for all of our older adults in Canada, keeping people happy and healthy at home. And my next slide, please. I'm hoping it wasn't too long, Trish and Harry. But anyway, so I really sincerely hope that I didn't talk too much. And maybe it's a little different from the previous presentations I've given you, because this has come an awful long way since then. We have a much better understanding of what it needs now to work in Canada, and we're in the process of building those solutions. We are having inquiries from municipalities in Ontario, chairs, mayors, wanting to know, how do we get involved? And I'm going to say to you, if you care about it, all you need to do is start a conversation with me, and I'll look forward to hearing from you. You've got my phone number, my personal cell phone number, you've got my email address. I will be happy to talk to you. Thank you.
Thank you very much, Paul. And yes, things have certainly evolved, which is why we wanted you back to talk a little bit about that. And I see a bunch of hands going up. I'm going to try and keep track of these. I'm just going to go with Jan, Sheridan, Carrie, and Donna first. And then I see Maureen has her hand up, and Dawn. So I'm going to just go through the list and put a list together and get to everybody. So Jan, you wanted to talk about membership fees for PACE. So please go ahead.
Thank you. Excellent presentation, Paul. I've been wanting to know more about this for quite a while, so I'm happy to be here today. You said earlier there is no membership fee for people to join.
For individual participants. So as if you were on Amazon Prime, you have to pay them to be a member. We would not charge you to be a member of PACE. When I say a member, I mean a participant, so the customer. The service providers, I'm being careful with the language, because the term member and association has legal implications. Our service provider members, they will pay a membership fee. We haven't yet decided on that, and we're working with our service provider members to help us build the association policies and a set of goals. One of the issues for us is making sure that we have a heavy governance model about quality and trust, because that becomes central to everybody's existence. So rather than us trying to make up a number and throw and throw it at the wall, we're not doing that yet. We will have that in the next few months.
Thank you.
Okay, Bill, I think you had a question. I'm just going to go down a list. And Maureen, you had your hand up. And William, if you want to ask your question later, I'll come to you also. Go ahead, Paul.
Bill, okay. Yeah, I hope you can hear me. Thank you, Paul, for your presentation. I'm the guy in the chat who was asking about the Norks.
Yep.
Large part because of where I live in Seton Village in central Toronto. The only people who are the go-tos on aging in place available to us that we've known of are the Nork Innovation Center. Right. So in raising the point, I wasn't asking so much about a competing interest as I'm seeing a lot of parallels in what you're doing and what this innovation center is doing, which is part of the University Health Network. And so rather than having a pissing match going here, there's lots of room for conversation, and certainly seniors such as myself who have been interested in aging in place and coordinating that for a long time, we need to see some, people getting together and not duplicating efforts and services.
Oh, please don't misunderstand my point. All I was getting at is when you need to have service providers coming to the building, you need to have places where they can come to.
Yeah.
The ambassador program is what I was calling the self-help groups. I got that when I was in New Delhi, talking about microfinancing, and the way microfinance works in developing countries is that you get the ladies in the village getting small amounts of money from a small bank, and then they get to work to add value and create things like bamboo fences around the village that create food and income and safety. the whole premise of self-help groups is very, very, very valid. Don't misunderstand me. Been there, done that. But the trouble with them is maintaining them and sustaining them. When you get to the next level, which is the integrated care model, then you get to the philosophy. And what I'm saying to you is, I've been around this now for long enough to be sold 100% on the Chinese philosophy, which is trust and care and actually love and integration and collaboration. When you look at the Unlock protocol, it's nothing to do with it is nothing to do with self-help groups or ambassadors. It's got everything to do with making sure that we know what is going on with the person and what they need to be self-directed, and whatever it takes to get them what they need to have a happy and healthy life. Does that help?
Bill, you'll be happy to know, SSL has formed a provincial panel, the NORC Policy and Implementation Panel, and UHN is on that panel with us.
Yep.
So we will be talking to the Ontario government soon about how they should be supporting NORCs, because Paul has made a very good point, which is that they often fund and build accountability mechanisms incorrectly and just create a lot of paperwork, which is useless. So we're going to be talking to them about that and about how they can best support NORCs instead of just loading them with paperwork and bureaucracy. So that will be an ongoing conversation. And Paul and I are also going to continue the conversation about small neighborhood homes, not for profit, in the community, no more than 6 people. So
I'm okay with size.
yeah, oh, I know
It's
you
the care model that I care about.
exactly.
Okay,
So
and that's very helpful, but if I may, the issue for us in Seton Village is, okay, now Paul's talking about the vertical NORCs, which, yes, NORC Innovation Center, they've been focusing on the vertical NORC, so big apartment buildings. They have resisted until now the idea of horizontal NORCs, and what I'm proposing to them, and they're taking an interest in, is having the vertical building as a hub, but then private residences, such as we have a lot of in Seton Village, being served as kind of hub and spoke.
yeah,
And this is where I see there's parallels with what you're doing, and there's room for conversation, and let's get some talk going on here.
yeah, Ray Applebaum at Peel Senior Link, which Paul knows Ray very well. He developed the hub and spoke model, and he is working with us on our provincial panel. So we're going to be talking about horizontal NORCs as well as vertical ones.
Oh, okay. Well, I think probably Seton Village Residents Association, which I'm a part of, should be talking to you guys too.
Okay, well, send us an email and we'll get you involved.
Listen,
Okay.
I think everybody should work together, because in the end, the more people we have focused on improving the quality of life through the four perspectives of bio and social and spiritual, we need to be taking everybody and thinking about this. As I've said, in terms of the UHN model on the ambassadors program, I think it's consistent with my own work, and I believe in it. I'm just saying that it's a question of sustainability. I have lots of different questions about it, but I know that what I'm proposing is not that.
Yeah.
It can work with it.
Yeah. No, it is different, Paul. You're absolutely right. And we're going to talk more and put out more information about the different models for sure, so that people aren't confused by them.
Yep.
Okay, I'll be in touch.
Okay, good. Can I talk? Maureen, did you have your hand up or?
Yes, I did. Actually, I'd like to know the name of the person that is in Seton Village, or I'll contact you, because we're setting up in Ottawa, Alta Vista, a horizontal NORC as well, and the sustainability, and it is an integrated model with 3 pillars, including the health services as much as we can. So very interested in that. I'm just wondering, our speaker, is he an actual municipal councillor? Did I understand that right, or what?
I am an actual.
He's the deputy mayor of Burlington and a councillor there.
And
Okay.
region.
Just what
Region
how
Halton too.
municipalities get into that. We have some councillors that have supported NORC and aging in place, but how do we go further? And I guess the answer is that I should get in touch with you then, with the speaker.
Indeed, please do that. If you look at the Trish will give you my contact information is on the slide deck. But it's really simple. For this purpose, it's paul@paulsharman.ca.
Okay, thank you so much. Very interesting. Thanks.
Thank you.
Hey, William, I think question for Paul. Are you there, William?
Yes, I am. Sorry, my laptop was running out of power. I had to go find a power source. So
Okay, go ahead.
I just want to thank you, Paul, for coming and giving us an update on the PACE program. I listened to some of the earlier presentations, so it's good to see the update, and I'd certainly like to hear more about PACE Canada, and good on you in getting it, helping organize it. I had a question about in Halton about you said the health teams were involved in it. And I was wondering, was that a private health team clinic or was that a community health team? And also part of another question was in Ottawa, where I'm from, we have a lot of community resource centers which offer more social and psychological type of services to the community. Was there, do you think that could get involved in the PACE model, or was it involved in Halton?
Okay, so you remember the hubs I mentioned, William, and we had the community development and program. So we would invite we would want everybody who does that. I can't even begin. There are names I can't give you yet, but you would know them instantly if I mentioned who was engaging in our community development and programming area. Is entirely what you just suggested. We want everybody in collaborating with each other and building a program that can be deployed across through to everybody in the community.
Okay. Jesse, you've got your hand up.
Yes, I do. Paul, thank you very much for this presentation. There's a lot of new information that I will share with Toronto Seniors Housing Corporation. My specific question is that 5 of your wellness hubs are funded by the community health in Burlington or Halton.
Mm-hmm.
And I'm wondering how you go about working with the existing legislation that has prohibitions against community health housing corporations providing services as care providers.
Well, they all have community housing. I'm not sure I understand because we're working with parties in the community, and they come in and we're just coordinating the work.
So we're working with an integrated health care system, and one of the challenges that we have is that the housing corporation itself cannot provide health care.
Oh, no, nobody can because it's universal health care. But yes, all the healthcare services that anybody's entitled to continue to be provided by the healthcare system.
Yeah.
So you need the coordinators, you need the service providers to act as the agent to provide the services.
Yeah. So the comment about the home care coordinator, they get kind of anxious around the word coordinator because it has meaning within the Ontario Health at Home environment and in the healthcare system. That's why they use other terms here. The Americans call it the care at home coordinator. So the word coordinator, you can't have a license on that word, and the combination with care at home makes us, in my view, much clearer. And if I get taken to task by the healthcare system, I'll change it. I don't care. That's their problem, not mine. They can't change their name, but I can change ours. But yes, we had to find funding for that in the region of Halton. The Halton Council funded our coordinator roles initially, and then gradually, in some instances now they're being paid for by Ontario Health.
Yeah, and just to add to that, Jesse, Toronto Community Housing has had services going in there for a very long time on contract with community-based agencies.
Yeah.
So I don't know who's saying that they haven't done that, because they certainly have for at least 4 decades that I'm aware of, especially with mental health agencies. Harry, if you're here, can you just speak very briefly about that so Jesse knows what some of those arrangements were? Harry is my husband, full disclosure. And he ran a community mental health program for many, many years and did exactly those kinds of contracts. So Harry, if you're there, can you speak to it?
I'm here. Jesse, there's absolutely no problem with an outside agency coming in to a person's home. You know, the agreement that we had, that my agency had with Toronto Community Housing, was that they would be the landlord. Simple. We would be the service provider. We would help them find tenants who happen to be our clients. And it was a very good system because they were very concerned about evictions of people who had mental health issues. And by us providing service in their apartments, we were preventing evictions from happening. So they were very happy. It was a win-win situation, and so it certainly is possible to do that. An outside agency, they didn't pay my staff's salary nor mine. We did that through the Ministry of Health. So it was an outside agency at arm's length, but we did have a memorandum of understanding between our agency and the housing provider. Hope that helps, Jess.
Yeah,
Hey,
and
Jerry, I will follow up with that. I'm talking specifically about a different corporation, which is Toronto Seniors Housing Corporation, which
Same deal.
is separate. Then, yeah. So there may be models for that. I know of the model between Baycrest and Sunnybrook Hospital that Toronto Seniors Housing is using, or a lot having in the properties. The larger issue is scope and size. We have 83 buildings, and trying to provide the services that you talk about for all 83 buildings is the issue. To have an integrated health model that serves all 15,000 people who live in Toronto Seniors Housing, which involves having a needs assessment and people who can provide that. And then because in East Toronto, for example, we have 100 different service people or service organizations, being able to direct them to the services that they need. So it's not an individual service provider providing services to Toronto seniors. It's having a structure that will allow Toronto seniors to have the access and coordination of an agency or all agencies.
yeah,
If I can just comment on that.
I was going to say, Paul, go ahead.
We would have said that we had no chance to do anything 10 years ago. But we decided to do something, and we started off small and demonstrated with a pilot project of what might be possible. And in the course of the next year and a half, we've gone from 1 to 8.
Yeah.
So I don't get me wrong. We have a mountain to climb here. But the fact of it is that that mountain is growing every year by 3.5%. So if not us, who, as Ronald Reagan would say, if not us, who, if not now, when? Because I don't want to be on that mountain trying to climb up and find there's nothing at the top.
Paul, I think it helps that you're the boss because you're chairing the community housing, the Halton Community Housing Association. Toronto, and I can say this because we're a social advocacy organization, so I can say controversial things. The city of Toronto has a completely bureaucratic and antiquated system that has prevented innovation for probably the last 3 decades. So Jesse, I don't envy you your task on that committee because the bureaucrats will find reasons to throw up barriers and say it can't be done. The fact is Paul's doing it in Halton, and other communities and municipalities are doing it as well. And they have already done it for decades with the mental health system and partnerships. So I wouldn't allow them to tell you that it can't be done and there have to be these structures and all of those things. That's absolutely ridiculous because a lot of other municipalities are doing this.
Well, and talk about Ray Applebaum and Peel Seniors Link and what they've done there. I mean, it's Pace inspired, and he's been doing it for 10 years longer than I have, or maybe 7 years longer than I have. Kudos to him. Listen, I also would offer you that the Invest Toronto is highly innovative, and they are capable of being innovative and being flexible. So my message is simply don't give up. Keep going at it.
Don't give up, Jesse. And we're right behind you. We'll cause trouble if that's necessary. I'm going to pass on to Maureen. Maureen, you have another question.
Just a quick question. Have you spoken at all with Build Canada Homes? Because seniors need affordable housing, but we're trying to get them to that the models of housing have more complete integrated systems. So has there been any discussion at all with Build Canada Homes? I know there was a seminar that Trish organized, but I'm wondering if there was any link up in terms of what they could do to support.
In fairness, my focus has been on the care model, but I am working with experts in small homes, and we are working, with the experts who design PACE centers. So I don't know about lots and lots of Canadian organizations that are full of overhead and people spending money and talking a lot about it. My sole purpose is action.
Yeah, and just Maureen, just to respond to that question, it's up to the municipalities and nonprofit organizations to put proposals into Build Canada Homes, and their portal is open. So anybody can go to Build Canada Homes, see the funding portal, and put a proposal in. So that's ready to go. Paul hasn't had to do that. Somehow they have managed to pry millions loose from both the provincial and federal governments already. But Build Canada Homes is available to literally every municipality and nonprofit in Canada right now who want to build an assisted living type program. They're going to ask for intergenerational now because they don't want to segregate older adults. But certainly these can be built with PACE Wellness Hubs built in. So that's absolutely possible now, but they have to get going. Our nonprofits and municipalities have not been particularly innovative. I think they're kind of used to same old, but we now, for some reason, have a federal government, well, I think we know the reason, on steroids, that is now putting out the opportunity for municipalities and nonprofits to build housing again.
I want to comment on that, if I may. The critical issue for us is, yes, keep going in the communities and in the municipalities. We now got the other 95% of the population. As I work with other organizations, I actually see not-for-profits and independent non-government entities wanting to do this on a philanthropic basis. In fact, I'm working with one already. And we were just talking about a building that we have rooms put in 15 or so small homes in space they have, and you've given me a reason to now call Build Canada Homes. So thank you for the question, and Trish, you are going to join PACE Canada as a consultant, and we're going to make these things happen.
Okay. All right, and I'm not taking payment.
Nor do I, so don't worry about that.
I know.
Thank you very much. That's very encouraging because we want a model. They're looking for models, and I think it's important. Thank you.
Yeah, actually, the models are out there. They just have to get their proposals in, Maureen, to be honest with you. And once those proposals are in and the government's funding them, then those will be spread to other organizations.
Okay, thanks a lot.
We need to get going. Okay, are there other people who have any questions or comments before we go? Because I just wanted, Paul, before you go, just to ask a couple of things. You have a service coordinator I'm assuming, for PACE in the Burlington community housing programs? Is there a service coordinator who brings
Well, there's the service manager at the region.
manager? Yeah.
Yeah.
Okay, how is the service manager funded?
It's part of the funding of the regional Halton's staff within the Community Housing Corporation within social services.
Okay, that's perfect. So that, folks, is what you want to talk to your municipalities about, is funding the service manager to start this off in the community and start pulling together resources from the community. Because that's what people always ask, Paul, is how in the heck do we get this started? And the way to get it started, I think, is to start to talk to municipalities about actually doing this.
It's not the way we did it, and we succeeded. We started off with the community group, which included the service manager and other community members who said, "Gosh, we need this. Let's do it, and let's start that founding committee." And it was mostly not municipal employees.
Yeah, interesting. External organizations, a lot of nonprofits, as I remember, when you started.
Yeah.
Yeah. So speak to your social services commissioners, folks, and try to get whoever is staffing the seniors programs to start working with other community organizations to get something like this started. The other thing is, Paul, I'm assuming the PACE can be scaled up to serve a variety of age groups, not just older people, right?
Well, truthfully, if in a few years' time, keep in mind I'm taking the path of least resistance right now because there's so many of us and it's getting increasingly more. But I believe we could change the name of PACE from Program of All-Inclusive Care for the Elderly to being Program of All-Inclusive Care for everyone.
Yeah.
But we already can respond to anybody who needs support.
Yeah, that was my question, because Build Canada Homes is wanting to build intergenerational buildings that may have a high number of older adults in them. But
Yeah. So our building in Oakville I talked about, the people who are coming in from being homeless, they're not seniors necessarily.
right, exactly. And PACE serves them too, right? And you serve younger people with disabilities also, as
Yeah.
far as I know, right? And younger people who are struggling with mental health issues, who need a small apartment, could also access PACE services if they became members, right?
So the problem housing for younger people, whatever their ailment, whatever ails them, is fraught with problems across Ontario.
Okay.
And so I have so many young families whose child is turning 20, I think or 21, is suddenly not able to get the support they've been having in those prior years, and
Right.
there is nothing for them. And we in terms of advocating, we need to do an awful lot for so many different people.
Yeah, absolutely. Yeah, one of the things that we're saying to the provincial government, because there are huge waiting lists for people with developmental disabilities, some of whom qualify for community housing.
Yeah.
Presumably they could become PACE members if there's a PACE wellness hub in their building.
If you look at it from the point of view of PACE Canada, anybody can become a member of PACE Canada.
Right.
But we have to get there, and it will be, we will just have to evolve it. But we know what the model is. It's going to be scalable very quickly, and we just got to get there. So bear with us.
Yeah, that's what I wanted people to know, is that is possible, that it is scalable. So,
Yeah.
Okay, any other questions before we call it a day? Okay, seeing none, you're off the hook, Paul.
Well, thank you very much, everybody. It's always an appreciate. It's always I always appreciate having the opportunity to come and talk to SSAO, and I appreciate the passion and compassion that you have in your organization, and Harry and Trish's determination and their ability to keep on driving, and I'm there all the way with you. Thank you.
Thank you, Paul. And yeah, this is a great presentation. I see a lot of people very happy, and I'm sure that this is another one of those recordings that is going to see 600 people having a look at it afterwards. So thank you so much. It was great. And we'll continue our collaboration over the years, I'm sure. Thanks so much,
Thank you very much, everybody. Have a good day.
everybody.